The key shift I'd like you to make is this. This exam is not about knowing more. It's about thinking better, thinking like a consultant psychiatrist. For example, in a Maudsley textbook, it talks about how two psychiatrists may come up with a very, very similar summary about the patient, but may have two completely different formulations. So for those of you who might not have attended any of the courses before or haven't met me before, my name is Dr. Sanil Rege, and I'm a consultant psychiatrist. My clinical practice consists of outpatient psychiatry, inpatient care, consultation liaison psychiatry, addiction psychiatry, work cover-related presentations, the second, third, fourth opinions, complex private practice, DVA, medical legal, civil, report writing, neuromodulation, psychotherapy. And I mention all of this deliberately because psychiatry in the real world is broad. I consider my practice as diagnosis agnostic because what I've really been trained to do is to understand the problem, the issues at hand, and convert that into a problem-solving strategy. That forms the foundation of formulation and strategic management. And if I work in the setting that allows me to do that with time, continuity, and then I'm able to put these aspects into practice and work with other disciplines to help the patient. Because that's what forms the foundation of psychiatric practice. It's not about what's the diagnosis and what do the guidelines say. And you see, when I see the MEQ questions, I recognize them because they're slices of clinical practice. I can honestly say every question that I've seen in the MEQ, I can say, I've actually been in a situation like this. The person's name might not be the same, their age might be slightly different, but this theme resonates. It's no different to an athlete. A tennis player looks at every single game differently, but the foundations and strategy that they apply to each game has common themes. So what are the common themes that we see in MEQ? You might have a patient refusing medical care, a distressed family asking for information, a person wanting to stop medication, but the risk of relapse is not clear, a young person with self-harm, family conflict, bullying, social media exposure, and questions about gender. Each aspect that I've mentioned is a specific domain. An older person with constipation, ruminations, possible depression, or a possible neurocognitive disorder with clues scattered throughout the vignette. And it's my role as a clinician to look at what those clues are, but more importantly, to identify what those clues mean. This is what makes psychiatric practice so fascinating. Because if any of you have ever wanted to be a detective, this is exactly what a detective does. As Sherlock Holmes said, we're looking at everything almost like a blank slate, and we put the pieces together. We combine inductive and deductive reasoning.